Good morning and thank you for the opportunity to present our project today. I'm Leah and I co-led this project with Dr. Shirley Jonathon, and our project was the Early Years Autism Assessment Toolkit and Pathway, and that was for children referred who were under the ages of 5 years. We want to say a thank you to our wonderful team, to all the professionals involved in carrying out these new assessments, embracing the new changes and adapting their practice. So pre-COVID, most of our assessments for autism were clinic-based on hospital sites. And when the disruption occurred to the services, we had to really adapt our pathway. We usually use the Autism Diagnostic Observation Schedule, the ADOS, but because this isn't standardised with a social partner wearing a mask, we weren't able to use it anymore. So we did some research and we were pleased to find a growing evidence base for ASD assessment, autistic spectrum disorder assessment, and telehealth, which was really promising. So using this research and the new assessments that we devised, we built a new pathway and a new ship to navigate through the choppy waters and the ever-changing waves of the pandemic. So why is it so important that we keep the flow of assessments going for these young children? It's because we know that it's widely evidence-based that children with autism face inequalities. Early intervention is really crucial, and support for these families provides a huge difference. So we want to keep the flow of assessments going so we can offer these early diagnosis so that parents and teachers can support their children and better understand their needs. And this is even more important now with September, with the additional learning needs reform coming in, which will change the way that provision is organised for children and in their education.
So the main aims of our pathway included the fact that we wanted to personalize the diagnostic journey for each child based on their needs. This would fit with prudent healthcare. We know that one shoe does not fit all, so a child's needs would be different depending on their services would depend on their needs. We wanted to devise a prudent pathway which would provide timely, valid, and quality assessments. This would increase parent participation and co-production, and would move telehealth to the forefront. We wanted to continue the flow of assessments during the pandemic and to gain feedback from parents and use this to inform our future pathway. We wanted to enhance our families' experience of the assessment process, and we were hopeful that we would be able to reduce the number of assessments and thereby support the reduction of wait times from referral to diagnosis.
So the part one of our toolkit was the telehealth element, and this includes the parental interview and a specialist speech and language social communication assessment. There are many benefits to using telehealth for assessment, and the main benefit is that it provided us a window into the child's living room so we could see them in their natural setting with their familiar toys, interacting with their caregiver and their attachment figure, which provided us with such rich information about their needs and also their strengths as well. Because in a clinic setting, it's often artificial and they're interacting with a professional, which is an unfamiliar adult. So we felt that this was a much better representation and more meaningful of their skills. Also, the other benefits are that it reduced travel time to clinic as well, and it was less stressful for parents. So the toolkit includes elements of assessment that are for children pre-verbal, using single words or have lots of language, and it includes observation of parent-child interaction and play, and also coaching elements as well. So the therapist can provide coaching for parents to try things that elicit communication for us to view how they're communicating and how functional that is. The parents are prepped beforehand, so they know what toys to have available based on their child's needs and interest. And some of the examples of the coaching that we might provide is we might coach the parent to offer choices, to use props, blow bubbles, use puppets, and we can also use things directly over the screen that will stimulate the child's interest as well. And we found visual stimulating props much more useful, like this light up windmill that you can see on the page there. So with children with language, they also need additional assessment elements to the children who are pre-verbal. So we would need to obtain a language sample, and we can do that via book sharing and through play, talking about pictures over the screen. We would need to elicit conversation and assess their reciprocal skills. And again, we would use things that they're really motivated by. For example, in this second picture, this is a Minecraft background, and that was used for a child who really liked Minecraft. We would need to probe emotional literacy and social thinking and inferencing, and we would do that through picture sharing with our screen, talking about the pictures and eliciting conversation about what the person in the picture might do or say next, things like that. There's also the option of inviting the parents to share video clips of everyday situations, and we found that this gave us an opportunity to observe the impact of their differences in real life situations. And this was actually based on research through Smith et al. In 2017, who's developed a NODA app for the autism assessment. So we based this element of the assessment on that evidence base.
So the second part of our toolkit includes a new face-to-face assessment called the Brief Observation of Symptoms of Autism. This was developed by a team in UCLA, particularly for use during COVID. The parent would be the social partner administering the assessment and who would be mask-free. The clinician would be observing from a social distance, and this increases the parent co-production. We are engaged in a collaborative project with UCLA, providing data validation so that this tool might be used more efficiently in the future. There are 4 modules to the BOSA, and the higher modules provide more conversational prompts. We developed crib sheets to facilitate providing the interaction or providing the assessment, and coached parents to allow them to be able to do this. So our early years ND team consists of health professionals, so doctors, specialist speech and language therapists, specialist health visitors, and our colleagues in education, so specialist teachers, additional learning needs leads, and also early years specialist teachers. Our pathway demonstrates principles of prudent health care. We do only what is needed, providing a service based on need, thereby reducing variation and increasing co-production with parents, and hopefully reduce the footfall to clinic. So the first step in the pathway would be referral to the early years ND team. The family would then be offered a range of assessments from the toolkit. We would then discuss the evidence based on DSM-5 criteria, and we would then provide feedback to the parent and signpost them to different services, ensuring that each child has a tailor-made support package. We were also able to provide intervention while the child was on the waiting list. So our outcomes between September 2020 and March 21, we were able to achieve diagnostic outcomes for 85 children, 74 of whom fulfilled criteria for the diagnosis of autism. Without these new approaches, all these children would still be on our waiting list. Of the 55 children in this period that received a specialist social communication telehealth assessment, 23 received a diagnosis of autism without needing a further clinic assessment. So that means 42% were able to go direct to a feedback clinic. Some of these required face-to-face assessment because they had not been seen at all because of the virtual nature of our work. For the BOSA clinic, we included 62 patients in the project, and 51 of these were given a diagnosis of autism spectrum disorder. 9 of these either had a language disorder or global developmental delay. Our assessments provided rich information with a high confidence rating, and we reduced duplication.
We asked parents for feedback using digital questionnaires, and we were pleased to find that 93% of parents were strongly agreed that their child's communication and difficulties and their strengths were understood. And all of them, with the exception of one, said that they would recommend the session to those with similar needs. And for the patient experience of the new face-to-face, 95% of parents said they agreed with their child's diagnostic outcome. And we had so much positive feedback about these sessions. And both the feedback from telehealth and face-to-face sessions supports the finding of Resetel in 2013, who found that there was no significant difference in the reliability of diagnostic accuracy and parent satisfaction between face-to-face versus video call. So what's next? We want to continue to improve the family's experience of their diagnostic journey by offering a mixture of both telehealth and face-to-face. And we're going to continue to study the clinical markers to decide which children are likely to only need telehealth sessions and which children will still need face-to-face. And in our experience, this has been the children with sentence level language and also mixed presentation. And this is also congruent with the findings of Gerard in 2018, who found that remote clinicians diagnosed in ASD did not feel capable of ruling in or out autism in 13% of cases. So we also plan to improve the quality of our intervention pre and post diagnosis, starting with developing a new speech and language therapy programme where families are offered intervention as soon as social communication needs are first identified and while they're waiting for assessment. We want to continue to improve their overall journey and put the children and families at the heart of what we do.
We will now have a Q&A discussion. What were the barriers you faced during this project, and what opportunities did COVID offer?
So we did encounter a couple of barriers, but I think we've thought about that, and some of them were team related because the team felt a little bit nervous about doing things differently. But with reassurance and looking at research, we were able to encourage the team to at least try these practices out. We needed to undertake online training, so Leah was very good accessing the online training and making sure that we all had access to it. We all engaged really well, I think, with the training that was offered. We offered a whole team meeting to tighten the pathway because we understood and realized that there was variation in practice across our health board. And of course, it's always difficult to adapt to change. So our challenge is now ongoing to try to continue the impetus of the change and to keep the changes that we've built in ongoing rather than going back to our previous ways of working. And we needed to revise our administration processes because those were really difficult. For example, we didn't realize that we had no terms of reference for our earliest ND team. So we've established those referral criteria, have them written down, shared and disseminated within the team. We also developed a clinic pack for use. And then obviously we had to acquire new equipment. So we had to approach our managers who were very kind, helping us to acquire the equipment, fix the audiology video equipment that wasn't working in our one-way clinic room. So that was fixed for us, and also getting the PPE ready, etc. And then also the professional's capacity to deliver the assessment and continue the new pathway. And we've highlighted this to our senior management team and our clinical directors who have been very supportive of us to continue this work.
I just wanted to add that I don't think without COVID we would have revised the pathway. We would have continued carrying out face to face, and so in a way it was a positive thing that it made us refresh our pathway and look at things that weren't going so well and that could be changed. So in some ways, I think it's given us that drive to kind of make those changes.
What negative feedback helped you shape the project?
So yeah, we had one family that wasn't satisfied with the diagnostic outcome, and I think in this nature of work, when you're given diagnostic outcomes, there are always going to be families that aren't ready for a diagnosis or feel that they disagree. It's a very unsettling, emotional time, and parents are grieving as well. So I think I think having 100% parent satisfaction rate may not be achievable actually, because they're all at different stages in their journey. And so we were really happy with that outcome. but I think it's important to still listen to people who are dissatisfied to see how we can improve that, and maybe they're just not ready to go, to carry on.
How might we encourage others across Wales to use this approach?
Well, we've been sharing our project quite widely. Last week we presented at the Health Technology Assessment International Conference. Our abstract was accepted and we presented on that platform, which was really exciting. And Shirley has presented the project at the Royal College of Child Health and Paediatrics and the Welsh Society as well. And tomorrow we've included a poster at the Together for Young Children session. So we're happy to share the project and share our learnings as well, share our reflections of what can make it better, what we've learned from it that would make it better for other people to try. But we're sharing it as much as we can, time in the capacity of our time, I suppose.
Yes, can I just add something? We had a poster presentation at the Royal College conference, and there was an oral presentation by a consultant in Sussex, and they are working on establishing a multi-agency pathway, which I thought, wow, they are 10 years behind us in Wales. And he gave one sentence of acknowledgement to Wales, saying Wales are way ahead of us. So he actually has asked me a question about the poster, and I've responded to him, but I'm going to share with him our video and say this is actually our entire oral presentation, which unfortunately we weren't accepted for at the college conference. It was a poster presentation, but in many ways I felt the poster was more beneficial because it stayed on the platform. It's going to be on the college platform for many weeks to come, so people can access that and look at it. So I'm definitely going to share with him because he's going to try to set up a multi-agency network in the trust that he works. So I think that might be a good route.